Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers Podcast. I'm excited to be sitting here today with the wonderful Paul Mango. Paul is the former HHS Deputy Chief of Staff for Policy at the White House. Paul was in the thick of it during COVID, was put in charge of Operation Warp Speed, and has so many fascinating things to talk about. And so, Paul, thank you so much for spending time with us today.
Hey, Mendel, thanks for having me. Glad to be with you today.
So let's quickly take a step back. Tell me how you got involved in healthcare and how you made your way to the government.
Oh goodness! Well, I actually started my professional career as a field artillery officer in the U.S. Army, and then I went to business school and I joined McKinsey and Company. And when I joined in the late 80s, they really didn't even have a healthcare practice. It was a different consulting model at the time. But then in the mid 90s, they decided that needed to organize much more along industry sector. And it was completely serendipitous, but I got on an engagement that was a healthcare supply chain engagement. I had never done any healthcare work before. And did about a year and a half of that. And if you do a year and a half of that with 2 or 3 clients, you all of a sudden become an expert and started serving hospitals and health systems. And then over time, one of those health systems had a health plan. So they asked for help on the health plan. So got to know a little bit about health insurance and just all kind of expanded from there. And I wound up spending 25 years serving, different health insurers and different health systems on a variety of topics ranging from, post-merger integration, the growth strategy to operations effectiveness, and really just gained a tremendous appreciation for what is a complex sector that does a lot of good in our society, obviously. And the more we can advance that, the better off we'll all be.
Yeah, amen. What was one of the most surprising things about the healthcare system? I think you put very nice words to it, but it's obviously very convoluted. It's very, there's a lot of issues with it as much as there's good with it. And so what was maybe one of the more surprising things to you when you started getting involved on the business side?
I would say how much impact the regulations have on this industry. I mean, there's a lot of parts of the U.S. economy where, regulation is a bit lighter and you don't have to worry about 9 Medicare rules coming out every year, statutory rules and what that means. But healthcare, and there's, obviously you could take airlines and a few other parts of the economy where regulatory change is really hugely disruptive. It could be positive disruption, could be negative disruption, but you have to keep a very close eye on it and anticipate what's trying to happen, what will happen over the course of the next couple of years. And a lot of that has to do with changes in administration too, because there's a big difference between the philosophies of one versus another. But certainly the regulatory impact on the industry is significant and growing, and was a bit surprising when I first got into it, because I had been doing work for steel companies and paper manufacturers and those types of organizations, and they didn't have the regulatory lens like healthcare does.
Yeah, that's for sure. And I know I'm kind of fast forwarding a little bit to the end, but I'd love to double click on something that you mentioned, which is the topic of how, every 4 years and max every 8 years, there's going to be a change in administration, and that's going to change a lot of the key people creating policy. And it seems so counterproductive in a sense to healthcare, where in healthcare you have to be able to have, CMS and CMMI, they continuously are coming out with these different models, and they just came out with another one. And there's this ACO model, and that ACO model, this value-based care model, that value-based care model. And it seems like there's so many coming out. And I'm sure for them, I mean, you're talking about, tens and tens of maybe hundreds of millions of people that are being affected by these by these models, and that you're trying to collect data on in order to determine the efficacy of such models. I'd have to imagine that you have to be able to have a window of 10, a decade, 20, 30, 40, 50 years in order to really, be able to create some sort of effective model. And so it's so interesting to me how that dynamic, how does it work that every 4 years you can expect a total upheaval of an administration that can really affect healthcare. So I know that wasn't really as much a question as, but how in your view does the change in administration affect the downstream policy in healthcare?
Yeah, well, maybe I'll start with what you were describing, Mendel, which is, some of the models, because CMMI, which is the Center for Medicare and Medicaid Innovation, was a creation of the Affordable Care Act in 2010. So it didn't exist before then, and it's buried in CMS. It's one of the 6 centers within CMS. And to your point, these models that come out, they're usually 5-year models, and they're demonstrations. They're trying to understand whether changing incentives or changing the parameters of how patients are cared for will actually change impact on quality and or cost. That was the statutory direction that came out of the ACA. And then there's a question of, okay, if it does have a positive impact, how do we work that into the regulatory process to make it more enduring? But one of the things I realized when I was at the federal government, now moving to the larger picture, is just how much influence the administrative state, I think they call it, has on these industries. And I mentioned a moment ago, there's 9 statutory regulations that come out every year just for Medicare. There's obviously rate notices that influence the Medicare Advantage, and then there's also different notices that influence the individual marketplace and so forth. And there's an immense amount of discretion that one administration has. And I'll just give you a clear-cut example to illustrate this. For Medicare Advantage, our administration under President Trump and Secretary Azar was a big believer in Medicare Advantage. And the fundamental belief was the following. Seniors, when they become, 65 or older, they tend to have 3, 4, 5, 6 different chronic conditions, very complicated to care for them. And in a fee-for-service environment, that's difficult to manage. But in a environment that Medicare Advantage offers, where there's more coordination and integration between payment and provision, we thought philosophically that's a much better way to manage chronic disease and prevent the progression of chronic disease. This administration is a much bigger believer in some of the ACO REACH models and the CMMI models. Not to be too cynical about it, but I don't think they're as big of a believer, this administration is, in the power of the private sector to innovate and to do things better. Whereas we believe that the private sector could probably move quickly and more effectively than the federal government in managing these patients. So, that's a pretty fundamental difference between 2 administrations over just a couple of years. And my anticipation is if the administrations change again, it'll go back to trying to enable private sector companies to do the hard work of innovation on behalf of the government rather than the government trying to do it itself.
Now, would an example of that be, last year they came out with a rate change that totally threw a ton of massive companies that seem to be doing really well in the value-based care space for an absolute loop, totally messed with the reimbursement model and the reimbursement, capabilities of a lot of these organizations doing hundreds of millions of dollars and caring for, tens of thousands of patients. Is that an example in your view, of one of those differences in how it actually is applied?
Absolutely. And I think what you're referring to specifically involved how risk accuracy was performed and the audits that would take place. And just to confirm what you said, it was just last week that the final rate notice for Medicare Advantage 2025 came out, and you saw, the stock prices of Humana and United and others dropped pretty significantly. So it just reinforces the point that the regulatory influence on the long-term outlook of these companies is pretty significant.
Yeah. Well, okay. We could do a whole hour just on this subject, which is fascinating, but it would be bearing the lead. So you were in charge of Operation Warp Speed, which is crazy. That is for those that are unfamiliar, that's the operation under President Trump that created and distributed the vaccine initially. And so I wouldn't say I know a bunch about it, but I did read. I did read Jared's book, Breaking History, I think it was called. Yeah. Loved that. Listened to it, and he had a whole chapter on the intricacies of that operation, how it really took off. And this really ties into what you're saying now, because a lot of that, just from my initial understanding, a lot of that depended on that fundamental understanding that you guys had and have, which is that the private sector, can move really quickly and get things done, and you guys partnered in a really serious way with, if I recall correctly, Walmart, and some other private sector massive companies to be able to put together pieces of I remember there was machinery that was put together and actually distributing the vaccine, and you guys leaned a lot on the private sector. So that's kind of all the knowledge I have about it. But let's zoom out. Let's step into let's see, what was it, February of 2020 when it really started breaking. So let's step into Paul's shoes back in Washington in February of 2020, and how do things start unfolding?
Yeah. So first of all, I think saying I was in charge of Operation Warp Speed is a little bit of a kind of an optimistic statement. I would say that I was facilitating its success. We had some great leaders, from President Trump to Secretary Azar to Moncef Slaoui and Gus Perna, General Perna, on down. So my job was to make them successful, but they actually ran the enterprise. In February of 2020, we were meeting at 7:30 every morning with a group within Health and Human Services to try to understand more about this novel coronavirus. It was still early days, if you think about it. And Tony Fauci came in one day and said, I've been in this for 40 years, and I've never seen a virus that has two characteristics simultaneously. One, that it can spread asymptomatically, meaning you don't even know you're spreading it. But two, that the clinical impact is tremendously asymmetric, which means some people get sniffles, other people die within 5 days. So when we digested that and knowing a little bit about the American people and what they could respond to and so forth, it was about that time we said there's only one way out of this. We have to develop very quickly therapeutics and vaccines because of the characteristics of this virus, or it's going to kill a lot more Americans. And so that got the gears moving, if you will. And then it was really Secretary Azar had spent 10 years in the pharmaceutical industry, and he understood what motivated them and what didn't. And they were fundamentally risk-averse organizations, if you think about it. So he's the one who was actually the architect who said, we have to assume the financial risk for developing and manufacturing tens of millions of vaccine doses before the clinical trials are even completed to determine whether or not the FDA will authorize the use of these. So basically everything that used to be done in series in terms of the development and manufacturing and distribution of vaccines or any type of drug was now being done in parallel. And the other thing that Secretary Azar realized, just having been at Health and Human Services under the Bush administration, is that HHS could not do this independent of bringing in some private sector experts. So in March of 2020, we made a call. He made a call to the CEO of BIO, and BIO is a lobbying organization in DC, and said, who's the best vaccine developer in the world today? And who's the best manufacturing expert? And 24 hours, we got two names back. One was Moncef Slaoui and one was Carlo de Natale Stefani. And those two became our leads, respectively, in terms of chief scientific officer and chief manufacturing advisor for Warp Speed. So the program was architected as we need to assume risk from the private sector. We need to engage them differently than we've ever done before. And we need some experts that are not government officials to help us through this. And the plan was fully developed in the month of April. The president had a Rose Garden event on May 15th of 2020, kind of telling the world that we're going to have safe and effective vaccines before year end. And sure enough, in the second week in December, we started distributing tens of millions of vaccines to the American people. So it was really a couple of principles, Mendel, that we adhered to. One was the government should enable success, but the private sector has to deliver the success, which is what it did. And the second thing we talked about was never let the government's reach exceed its grasp. And what we meant by that was we permitted the states to tell us where they wanted, how many vaccines they wanted, where they wanted, and which type of vaccines they wanted, because we could not possibly understand, in one state it might be we want teachers vaccinated first. In another state, it might be we want people in nursing homes vaccinated first. Depending on the demographics of the state, Florida has a lot more seniors than where I live in Wyoming, for instance, right? So those principles served us extremely well. And again, the private sector, when properly motivated and given clarity of what the regulatory framework would be from the FDA, responded extremely quickly and, of course, effectively. And the prior record for bringing a vaccine to market was about 4.5 years. And under the Trump administration, we did it in 10 months.
Now, from a regulatory perspective and cutting red tape, what did you have to do internally in order to actually get that done? Because it seems impossible to me, even now, in retrospect, to get something pushed through that big, that quickly inside the federal government. So what did that look like?
Well, we had a great leader of the Center for Biomedical Evaluation and Research at the FDA. His name was Peter Marks, Dr. Peter Marks, great individual, great American, great scientist. And Peter understood we had to balance two things. One was we didn't want the American people to think we were taking shortcuts, but we had to do this quickly if we were going to save what eventually the Commonwealth Foundation of Massachusetts said about 2.5 million lives, right? So he did something that was very effective. He said, normally in a clinical trial for vaccines over many years, there's about 20,000 subjects that go through that trial, phase 3 clinical trial, human clinical trial. He said, we're going to increase that to 30,000. And the second thing is there was a typical wait period from the time, let's say you got the vaccine injection to understand whether there were going to be any side effects. And that was typically about 42 days. And he extended that to 60 days. So he actually set the parameters for this higher than for any other vaccine that the FDA had ever approved, the quality parameters, if you will, and safety parameters. But he also changed two other things that permitted speed. One is that he permitted the companies to submit the data along the way during the trial instead of waiting until the trial was over, so that the FDA could familiarize itself with all this information and not have to wait until the trial was completed. The second thing he did was he reorganized his unit at the FDA to work 3 shifts, 7 days a week. And he said, from the time I get the last bit of data and the submission for an emergency use authorization until the time I render an opinion will only be 14 days. Now, that may sound like a lot of time, but it's typically 6 months, right? So he had his team working around the clock on 3 different shifts, 7 days a week. He got the data early. So we traded safety, meaning more subjects had to go through the clinical trials. You had to wait a longer period to see if there were any side effects. But then the FDA tremendously accelerated its evaluation period, and we got there faster. So it was really brilliant, and Peter Marks deserves all the credit for doing that, because we, as an Operation Warp Speed team, could not tell him, the regulator, what to do, because then we would have been accused of manipulating the outcome. So he had to come to us with his plan and work in conjunction with the NIH, and they made that determination, those determinations. So it was very good outcome.
Was Peter a government lifer, or did he come from the private sector?
Very interesting. He started at Columbia University. He was an academic scientist and physician there, oncologist, treating oncology patients. Then he did go to the private sector, and that was very helpful. So it's an appropriate question. He understood how the private sector, operated, and then he had come to the FDA. I think he had been there at least several years before the pandemic hit, and he became the director of, as I said, the Center for Biomedical Evaluation Research, which is the center that approves vaccines and therapeutics. So he had a lot of experience in both the private sector and the government and the academic environment. So a good person for that role.
Yeah, the more I speak to people in government, both successful and otherwise, the more I'm convinced that it's absolutely critical for anyone in government to be in and out of government. Like spend some time in the private sector, spend some time in government and then be effective and then get back out. And then you want to come back. Okay. But like, it's because otherwise it just, my good friend, Dr. John White is the chief medical officer over at WebMD and currently, but he was at the FDA. He was at I think he was at CMS as well. And in between then he was at like the Discovery Channel. Anyway, so he was the first one to introduce me to this. He said that while at government, he would like, he'd be at, which is the total contrast of what you're describing, which is why it's so fascinating. But he'd be at a meeting and they'd say, okay, we're going to roll, it would be January. And they would say, okay, we're going to roll out this new initiative in June. And somebody would raise their hand and say, okay, but of what year? Like with a total straight face, And he's like, everything was just so slow. So I asked that about Peter, because I can't imagine that he was lifetime in government to be able to even have the underlying, capabilities and understanding to move things to change the underlying things that will then move things very quickly. That's really it.
Yeah, he was fantastic. He's still there. He's still the head of CBER, so nice. Hopefully doing great things.
Yeah, I'm sure he is. So that kind of touches on the manufacturing of the vaccine. Let's talk about distribution for a second, because that's the flip side to the coin. So talk to me a little bit about how you guys started crafting strategy for the distribution.
Yeah. So just stepping back for a second, really, Operation Warp Speed was 3 sets of joint ventures. One was between Health and Human Services and the Department of Defense. And what the Department of Defense did was lend its entire Army Materiel Command leadership to Operation Warp Speed, and credit not only to Secretary Azar, but Secretary Mark Esper at the time. They were very collaborative, and apparently this type of collaboration had never really happened before between 2 departments. So that was one. The second joint venture was between the federal government and the states, and I'll come back to that because that had a lot to do with distribution. And the third, of course, joint venture was between the federal government and the private sector. On the private sector front, one of the things that we were very concerned about, because we knew these citizens would be particularly vulnerable, would be those in nursing homes. And if you remember, there were some outbreaks where there was, unfortunately, some very serious kind of case fatality rates in these nursing homes. I think in some cases, 60, 70 Americans died in the nursing homes because of COVID. So we contracted with CVS and Walgreens, and what their job was to go out to. There were at the time about 1.5 million Americans in nursing homes, and there were about 15,000 nursing homes. So you can do the math; it's about 100 persons per nursing home. And we wanted to prioritize getting them vaccinated. So CVS and Walgreens worked with the Army Materiel Command to develop plans to get out not only once, but twice. Remember that you need 2 doses for both of these vaccines. The Johnson & Johnson vaccine wasn't approved yet. Right. And they made their rounds to 15,000 nursing homes twice in 6 weeks, in 6 weeks' time, because you had to wait 3 or 4 weeks, depending on which vaccine it was. For the second one, just absolutely extraordinary. And I remember Gus Perna he flew back from Rhode Island one day after visiting CBS to review their implementation plan. And I saw him that night, and he said, I've been in the Army 40 years. I've never seen as detailed of a plan as what CBS had to go out to these places. So just another example of how the private sector did wonderful things during this COVID response. As it relates to the states, this was a big challenge because what we knew for sure is we wouldn't have 300 million doses of any single vaccine by the time these things were approved, because we had to spread our bets around. We didn't know which vaccines were going to win or lose or whatever. So while we had well over 100 million doses of vaccine manufactured,
sorry, I don't mean to interrupt, Paul, but yeah. Did any lose?
Well, yeah, we had 6 vaccine candidates. Only 3 were eventually approved. Well, I think the 4th one very, very late, like 2 years later. So, you had Moderna, you had Pfizer, you had Johnson & Johnson. Those were 3 of the horses we backed. But AstraZeneca never got approved. Novavax got approved very, very late. And then GlaxoSmithKline, Sanofi, which is a joint venture, never got approved either. Wow. So, but we were manufacturing along all 6 of those, because we didn't know which one was going to win. Yep. Now, once we saw the winners, we could shift all the manufacturing capacity to the winners, which is what we eventually did. But the point is, we weren't going to have enough vaccines for everyone who wanted them on day one. We just weren't. So what that meant was there was going to be scarcity, and therefore there had to be an allocation system. And we had to keep track of where all these vaccines were going. So the Army Materiel Command, working with Palantir, which did a great job during all this, set up a software system where we could track every vaccine, exactly where it was going, how many were used, because each week when we had an allocation to the states, we would have to tell the governor and his staff, his or her staff, last week we shipped X number to these locations. Right. You only consumed half of them. Is this where you want us to send more again, or do you want us to send them to someplace else? And every vaccine site had to be enrolled in our system. And there were eventually 50 or 60,000 that we enrolled before the middle of December. And there was a software link to them so we could make sure we understood the status of all these vaccines. So it was an immense task. And, I should mention FedEx and UPS did a fantastic job as well. What they did was they developed, we had boxes where we were going to ship the vaccines. They required dry ice because some of them required minus 80 degrees Celsius transport. And they had motion detectors on each of these boxes because if someone shook them too harshly, the glass could break, the vials could break, that type of thing. So we could keep track of that, and temperature gauge. So we could track that they stayed at minus 80 the whole time, and a GPS tracker on each box so that we could tell every 2 minutes we got a signal, whether it was in the ground or on the ground or in the air. We got a signal as to where that box of vaccines was, because we'd be getting calls all day long. Where's my vaccines? Are they going to arrive on time? And we could say, they're over Omaha, Nebraska right now, but the plane should land in Chicago at X time or whatever it was, right? So that was an immense task, and it was very effective in the sense that we could keep track of everything, and we could guide the governors and their staffs as to what was happening. As Gus Perna said, I want to see my battlefield. That's what he called it. I want to see my battlefield every minute of the day. But we let them make the decisions. We let them tell us where they wanted, in what quantities, from which vendor, and all we did was deliver, right? So we didn't want to get in the business of setting their priorities. That's why we said never let the federal government's reach exceed its grasp. Let's let the local leaders determine the final mile, so to speak.
Yeah. All I can think selfishly, personally, is like, seriously? So UPS and FedEx was able to do that, but they can't put one tracker on one truck, on each truck, so I could see where my package is.
Yeah.
All we get is every is the points, not all the way. But that's absolutely fascinating. And look, this isn't a political show at all, but I think it's an objective truth that there's been a massive shift in it. It's even weird to think back to 2020. There's been such a shift politically around the vaccine, where initially it was the Trump vaccine and half the country was saying we'd never touch that thing. And then now it's become, it's the Biden vaccine, and the other half of the country won't touch it. From an operations perspective, because I believe that's your lens, right? What could have been done better in the rollout, or what was done wrong throughout? What are the underlying things that created such a drastic change? It's weird to think about, but literally we're on two opposite sides of the same view of one central thing. It's weird. What are your thoughts?
Yeah, it's hard to separate that question from the politics of the day, but let me tell you what I think one thing that we could have done a lot better, and if we ever got in the situation again, we would do it differently than the way we did it. And then I'll tell you what I think led to a lot of the backlash. We were very concerned about being accused of manipulating the regulator, as I said before. So we could have come out in September. We saw phase 2 results. We started to see phase 3 results as early as September. In fact, Pfizer came out and said, we think we're going to have good data by the end of October. They said that in the first week in September. And they knew, because they started their phase 3 clinical trials on July 31st. They already had thousands of folks through it. We could have said, American people, we think we're going to have some really good vaccines for you. Just stand by. They're coming. We've seen the early results. We would have been accused of manipulating Peter Marks and the FDA. Because if a president comes out and says, I think this is going to be a good vaccine, people would say, you're trying to signal to the regulator. So we chose not to communicate. Part of that was political, and part of it was just, in reality, we didn't want to influence the FDA. What we could have said is what I talked about a little bit earlier, and that is to the American people in the fall, we don't know whether these are going to be approved for emergency use or not. We have no idea. That's up to the FDA. What we do know is the standards under which they're going to be evaluated are higher than any standards ever used for vaccines. The 30,000 folks going through phase 3 clinical trial instead of 20, the 60 days instead of the 42. We could have communicated that aggressively and said, again, we don't know what the FDA is going to do. We're not trying to influence them, but we want you to know these are the highest standards ever applied to a vaccine approval evaluation. We should have done that. Where I think there was backlash against the vaccines is when the mandates came. We never would have mandated vaccines. That wasn't the style.
When did the mandates come in the timeline?
In the summer of 2020.
Okay.
I'm sorry, in the summer of 2021.
Yeah.
Because,
like all that area where like if you didn't get vaccinated, you're killing me. That whole mind bubble that has since very much evaporated.
Yeah.
Weird time.
And I think it was because, if you remember, the new administration said we're going to do 100 million vaccines in 100 days, and they started lagging and they got concerned, and then the mandates came. The reason the mandates were completely inappropriate, despite what any individual believes, I'm talking from a scientific perspective now, is because the primary endpoint of the phase 3 clinical trial was not if you were vaccinated, could you transmit the virus. It was, if you are vaccinated, will you avoid serious illness, hospitalization, and death? Okay. So the vaccine was never intended to prevent transmission. So what is the impact then of the message coming out that says you should get vaccinated so you protect grandma? Well-meaning Americans got themselves vaccinated, and then they went to see grandma at Thanksgiving of 2021. And guess what? They put grandma in danger, even though they were vaccinated, because the vaccine, as I said, the primary endpoint of the phase 3 clinical trial was not to evaluate whether or not you could transmit the virus.
In addition to that, that messaging directly defeated the message, because it didn't take that long for people to see that I got vaccinated and I still got COVID, or people around me still got COVID. I just didn't get it so bad. I got COVID. And so so when the whole thing was built on, and that's absolutely news to me, the fact that the whole messaging was built on transmission. Wow.
Yeah. Wow. Now, the vaccines were extremely effective as it related to what they were designed to do: prevent serious illness, hospitalization, and death. Now, it doesn't mean that even the Pfizer and the Moderna vaccines were 94 or 95% effective. So what does that mean? Even if 100 million people got the vaccine, 4 or 5 million could still get serious illness, hospitalization, and death. But, it was 94, 95% effective.
And in your view, now what's, the speculation around, blood clotting and heart disease, and a lot of side effects that are being speculated, do you think that that's just sort of, misinformation, or where do you think that lands?
No, I don't think it's misinformation. I think, the Johnson & Johnson vaccine was eventually pulled off the market because they thought that the risk of blood clots, particularly in women of childbearing age, was higher than it should have been. And I don't know, I don't remember whether Johnson & Johnson did that voluntarily, but they pulled it off the market. It's all law of large numbers. So, of course, there were some cases where there could be blood clots, or, I think myocarditis for teenage boys, I think was another one. But we're talking about, again, if you have 300 million persons vaccinated and you have a few thousand cases of side effects, and you did prevent 2 million deaths, it's all around trade-offs. I think what we should have done is understand, because we did, but the second administration didn't really want to push this, was we understood exactly who would benefit from these vaccines and who wouldn't, right? I mean, it's very clear who was vulnerable to serious illness, hospitalization, and death. And it's not a Stanford varsity athlete. So to to make one of them get vaccinated was ill-advised. We could have been much more targeted and had a similar positive outcome on preventing deaths, but not had as many side effects. But I think the public health community needs to get that straight next time around.
Wow. My goodness, Paul. I am excited to, so for those that are unaware, Paul actually wrote a book called Warp Speed: Inside the Operation That Beat COVID, The Critics and the Odds. And so I'm extremely excited after this conversation to read that book. Where is it available?
Oh, it's available on Amazon or Barnes and Noble. You can get it online. Wherever it's not in physical distribution at the airport, but you can get it online with all the sites that
books are available.
Distribute the books. Yeah.
Did you do an audio version or not yet?
Yeah, there's an audio version too. There's an audio version.
I'm gonna get it right now on Audible.
Unfortunately, it's not my voice. It's someone else's voice, but it's still the same text.
Let's see. Audible Warp Speed by Paul Mango. There you go. Right here, ladies and gentlemen, on Audible.
There you go.
So is it free on here? I don't know why it's showing free. It says just play. But anyways, I will be purchasing this if it's purchasable. If it's not, I will be listening to it. Fascinating. Well, I think it's thank you so much for spending time today. I think it's really intriguing. I think we could probably spend 6 hours together and probably some good bourbon and cigar. But for now, this was absolutely fascinating and eye-opening. And so thank you so much for spending time today.
Yeah, well, thanks for doing it. It's been my pleasure.
And besides for the book, I know Paul can be found on LinkedIn. Paul also puts out a quarterly newsletter that is really, really interesting. Paul, do you want to talk about the quarterly newsletter for a second?
Yeah, it's actually a trends. I do it on trends. What I just do, it's a little bit selfish. It's for my own benefit. I digest all the earnings call transcripts for all the publicly traded healthcare companies every quarter, look at what's happening regulatorily in the Federal Register, and I try to distill it down to 2 or 3 major trends with implications for big health insurers and big health systems providers, hospitals, physicians, and so forth. And I do it really for my own benefit so that I can really crystallize my own thinking every quarter, because I still have a big consulting business and that type of thing. But, I post it on LinkedIn, and it's interesting, get 20 or 30 or 40,000 people looking at it, and a lot of comments and questions, and I try to answer the questions. So it's just a good process overall.
Love it. Well, Paul, thanks again, and good luck with everything. I look forward to our continued conversation.
Thanks, Wendell. Thanks for doing this.